Today, I will present on fetal gastroschisis, defining interval growth. My name is Kathy Zhang-Rutledge. I'm a maternal fetal medicine fellow at the University of California in San Diego. I want to thank the Institute for the opportunity to present this work. The project is a collaboration of the University of California Maternal Fetal Consortium, which comprises of 5 medical centers: UC Davis, UC Irvine, UCLA, UCSF, and UCSD. We have no disclosures. Gastroschisis is a congenital abdominal wall defect that leads to herniation of the bowel and other abdominal contents. It affects about 5 in 10,000 live births. Fetal gastroschisis is associated with many prenatal complications, such as growth restriction, stillbirth, and preterm labor, as well as neonatal complications, including bowel atresia, ischemia, necrotizing enterocolitis, and prolonged NICU stays. Gastroschisis alone complicates the management of pregnancy, and the addition of fetal growth restriction in approximately half of cases further complicates the picture. We know that fetuses with gastroschisis are at risk for developing growth restriction and are at risk for stillbirth, particularly among 37 weeks gestation. However, these risks must be balanced with those of early delivery and prematurity-related neonatal risks. Gestational age at delivery is independently a strong predictor of adverse outcomes specific to gastroschisis population, such as reoperation, gastrostomy, and necrotizing enterocolitis. But at what point does the scale tip to delivery because the risk for fetal loss is too high? A key piece that we don't understand well is what the normal growth patterns are for fetuses with gastroschisis. What interval growth from week to week is acceptable, and what interval growth is small enough to raise concern about the need for delivery. The primary aim for this study is to define the mean estimated fetal weight and interval growth for fetuses with gastroschisis, to understand growth patterns over time and optimize pregnancy management. This was a retrospective observational cohort study of all fetuses diagnosed with gastroschisis from February 2015 to February 2019, who had at least one ultrasound at the University of California Fetal Maternal Consortium site. We collected information about maternal demographics, comorbidities, estimated fetal weight, or EFW, and biometric measurements. All consortium sites used Hadlock's formula to calculate EFW. For each gestational age at 24 weeks and beyond, we calculated the mean EFW. We also calculated the mean interval growth per week between 24 and 39 weeks. In addition to these calculations, we applied 3-point smoothing to the data to even out short-term fluctuations and highlight overall trends. These are our results. We identified 84 singleton pregnancies during the study period. This was a young cohort of women with a median maternal age of 23 years old. 64% were nulliparous, and the majority identified as white and Hispanic. The prevalence of preterm delivery was 54%, with a median gestational age at delivery of 36.9 weeks, which is similar to previously published studies. 48% of pregnancies were diagnosed with fetal growth restriction, defined as estimated fetal weight less than the 10th percentile. The median birth weight was 2,575 grams. The mean interval growth per week was 164 grams based on raw data, and 171 grams per week using 3-point smoothing. This graph illustrates interval growth over gestation in pregnancies with gastroschisis. The x-axis is gestation from 24 weeks to 39 weeks. The number under the x-axis represents the number of continuing pregnancies in the cohort at each week. With advancing gestation toward term, more pregnancies were delivered. The y-axis is the estimated fetal weight in grams. The reference lines are based on Hadlock, with the 10th percentile in solid black, 50th percentile in dashed line, and 90th percentile in dotted line. We plotted our cohort's mean estimated fetal weight in blue and 3-point smoothing in orange. You can see that our cohort's mean estimated fetal weight and interval growth from 24 weeks to about 36 weeks remained just above the 10th percentile line. More fluctuations were observed between 37 and 39 weeks due to much smaller numbers of ongoing pregnancies, which is where the 3-point smoothing is particularly helpful to highlight the overall trend. In conclusion, nearly 50% of fetuses with gastroschisis met criteria for fetal growth restriction in our cohort. Their interval growth across gestation seems to approximate that of growth-restricted fetuses without anomalies, hovering at just above the 10th percentile across gestation. Strength of this study include that this was a large, multi-centered, contemporary cohort. The 5 centers are geographically spaced out in California and diverse in ethnicity and socioeconomic factors. We had a robust dataset with demographics, prenatal biometric measurements, and postnatal outcomes. Importantly, this study is novel in that it identifies the week-by-week interval growth in pregnancies with gastroschisis, allowing more evidence-based management decisions during these pregnancies. A weakness of the study is that this was retrospectively collected data. Because the contents of the fetal abdomen are externalized in gastroschisis, the validity of EFW, as traditionally measured, including abdominal circumference, is not entirely clear. Last, this study did not take into account postnatal outcomes for those fetuses with lower than mean interval growth or a diagnosis of fetal growth restriction. Future direction of this work include assessing the validity of abdominal circumference as a biometric measurement to include in the assessment of EFW and interval growth for fetuses with gastroschisis. We will assess postnatal outcomes for these neonates after birth to understand which ones had more adverse outcomes, such as bowel ischemia or atresia, and whether growth restriction or poor interval growth contributed to these adverse outcomes. Lastly, we plan to track growth longitudinally from fetal life to the neonatal period to understand which fetuses may be at increased risk for poor growth even after birth. Thank you for viewing. If you have any questions or comments, feel free to email me directly. I've also included the website for the UC Maternal Fetal Consortium if you're interested in learning more about the projects we are working on as a group.